السلام عليكم ورحمة الله وبركاته. معكم الدكتورة أروى السيد، استشارية جراحة اللثة وزراعة الأسنان. Today, inshallah, we'll be talking about the bone grafting material in implant dentistry. This is for the educational channel that will be seen by general dentist or specialist. My talk will be in particular about the grafting materials that will be used in perio and implant dentistry. Of course, all what I've been showing in this lecture with no interest of conflict. The alveolar ridge undergoes accelerated bone loss within the first 6 months following tooth extraction. We know when we extract the tooth, there will be alveolar ridge resorption, and an estimated 50% loss of the alveolar ridge will occur after tooth extraction. With the tooth, when we extract the tooth, there will be loss of the periodontal ligament and the loss of what's called bundle bone. Buccal bone also resorbs more than the palatal or the lingual plates. Center of the ridge is shifted to the palatal or lingual side. We see when we do the extraction and there will be resorption of the buccal ridge, it will shift totally to the palatal or the lingual side. Analysis of this defect that occurs after tooth loss is the basis for deciding what kind of treatment we should provide this patient, whether we augment the socket or we build the ridge, ridge augmentation, or we do immediate implant right away. There have been a number of proposed systems to classify the bone defects, and accordingly we will decide what type of treatment we will provide that patient. This classification of bone defect will serve to simplify the description of the residual ridge and thereby assist in the communication between the clinician, and also will aid in the selection of the appropriate surgical and prosthodontic techniques or treatment that the patient will receive. The first and well-known classification for bone loss following tooth extraction is by Lickholm and Zarb as early as 1985. These people, they are the first to recognize that there will be dimensional changes that occur to the ridge after tooth extraction. And this classification is based on the volume of remaining mineralized bone. The edentulous site were classified accordingly into 5 groups. Group A, B, C, D, and E. A, B, you see there the substantial amount of alveolar process still remain, and here we can put implant and augment at the same time. While group C, D, and E, there is very minor amount of alveolar ridge process that present at the time where you have to build with Otogenous or some other techniques of ridge augmentation. The other and most commonly used classification for bone defect, which I personally like to use, is by Seibert as early as 1983. He classified the residual ridge deformity into 3 categories. Class 1, where there is faciolingual loss of the tissue width and normal ridge height. So there is horizontal bone loss, but the vertical height is maintained. Class 2, it's the opposite. The vertical ridge height is reduced with this group. Class 3, combination of loss, horizontal and vertical bone loss. Other classification that was mentioned in the book of Clinical Periodontology and Implant Dentistry by Lindy group, it is based on it was classified into 5 groups, and with this classification you can decide what type of treatment you will provide the patient. So it's very profound, really meticulous classification, which I personally like to use as well as the Seibert classification. Okay, class 0, it's a healed side where you put the implant with a complete bone formation in a native bone. Okay, that bone is native. You don't augment, you only put the implant right away. This group, the tooth is extracted long time ago, but the ridge is maintaining the size of the bone. The graft material and a membrane might be used at this case just for augmentation and to build up the ridge or for aesthetic reasons. Extraction socket class 1, where the bone augmentation is required at the time of implant placed immediately into the extraction socket. Flap should not be raised at this group, and the bone graft material is placed in the space between the socket wall, the buccal socket wall, and the implant surface. So there will be extraction and immediate implant placement, but the bone should be placed between the buccal bone and the implant surface, i.e. the bone will be placed in the jumping gap. Class 2 and class 3, where there is dehiscence after tooth extraction, and it varies between class 2 and class 3 being minor or major. In all ways, you need, when you place the implant, you can place the implant immediately, but you have to have a primary stability at the time of implant placement, and augmentation will be concomitant with this type of immediate implant placement. If the area has high aesthetic demand, then you should augment before you put the implant. So you don't put the implant immediately, but you augment the socket and then wait for healing and then come back to place the implant. This is in high aesthetic demand. Otherwise, whether the dehiscence type 2 or type 3, you can place the implant and augment at the same time. Type 4, here where you have severe loss of bone, you can have two options. Whether you put autogenous bone graft, okay, and cover it with a membrane, or you can use what's called tenting. You put screws and you put allograft or xenograft, demineralized bone, bovine bone mineral, and cover it with resorbable or non-resorbable membrane and leave it to heal, and then after that you remove and put the implant. So the implant won't placed immediately, you have to augment the site and then come back after 3 or 4 months of healing and put your implant. Last group or last class after tooth extraction, class 5, where you have severe bone loss, and in this case autogenous block graft is the only recommended treatment. You cannot put tinting, you cannot put any screws at the side, you have to put a block, fix it with screws, and then cover it with a membrane, come after healing and put your implant. The third technique or third classification, which is a simplified socket classification by Alien and Tarno and Smith. This is really, it will tell you what kind of socket you're having and what type of treatment as well, but it's only 3 classifications: type 1, type 2, type 3 socket classification. Type 1, the facial soft tissue and the buccal bone plates are maintained. So after you extracting the soft tissue, extracting the tooth, the soft tissue and the buccal bone are still there. Type socket augmentation requires no augmentation after extraction. You can put the implant immediately, but you can put little bit of bone in the jumping gap. So it is similar to type 1 extraction in the previous classification. And this is an example, tooth number 11. It is hopeless because it has external root resorption, but look at the buccal bone here. It has thick buccal bone and the soft tissue is well maintained. It's a thick tissue phenotype. In this case, you can extract and put the implant immediately. Type 2 socket, where you soft tissue is there, but you have loss of the buccal bone. In this case, you have to augment the socket with bone graft and a membrane. So in this case, it's advisable not to put the implant immediately, but to augment and then come back after healing for implant placement, particularly in the aesthetic zone. So that's an example, tooth number 21. It has loss of the buccal bone, but the soft tissue is still maintained. So in this case, we extract, augment the socket, and then come back and do the implant in a healed socket manner. Type 3, socket where you have both the soft tissue and the buccal bone are lost. In this case, you have to extract the tooth and then augment the soft tissue first, and then augment the socket and come back with the delayed mode of implant placement. And that's an example of type 3 socket, where you have no soft tissue and no buccal bone. So we have to extract the tooth, build the tissue and the bone, and come for after that, after healing, for implant placement. Okay, bone graft and bone graft substitutes. The biological mechanism forming the basis for bone grafting, including 3 basic processes. So when we graft the site, we are looking for healing for 3 methods, whether healing by osteogenesis, osteoinduction, or osteoconduction. So the bone grafting materials you are using will follow one of the 3 biological mechanisms for augmentation. The first method, osteogenesis, occurs when viable osteoblast and precursors mesenchymal cells are transplanted with the grafting material into the defect site, where they may establish center of bone formation. Osteoinduction, it involves new bone formation by the differentiation of local connective tissue cells into bone forming cells under the influence of the inducing graft material. Osteoconduction, which is considered to be the least type for bone formation, it occurs when non-vital grafting material, whether it's allograft or xenograft, serves as a scaffold for the ingrowth of the osteoblast cells into the defect site. Okay, so what are the type of bone grafting materials that we are using to fulfill the type of augmentation or type of healing? We have 4 types of bone grafting material: autograft, allograft, xenograft, or alloplast. Okay, the autograft is considered the gold standard of bone transplantation because it is osteogenic, osteoconductive, and inductive. So the autograft, it fulfills all the type of healing with the grafting material. So it will be extraoral or intraoral. Extraoral, it's taken from iliac crest, rib, or calvaria. Intraoral source is taken from the chin or symphysial, retromolar, ramus, or buccal sinus wall. The autografts are highly advantageous since there is minimal to no risk of transmitting of infection, because it's taken from the same patient. So it doesn't transmit any disease and no immunoresponse after transplantation. However, there are some associated risks, such as graft resorption if it is extraoral, for example, if it's taken from the hip or the rib, because of osteoclastic activity, so it might resorb quickly. Donor side morbidity, limited bone availability. Sometimes if you want to graft the whole mandible and then or the maxilla, and you don't have enough material or enough bone grafting material. Dropping of the chin if you take symphysial bone graft. Some patients, they complain of the dropping of the chin because you are really dissecting some of the muscles at this area, particularly if you do it beyond the genial tubercle. So if you cut the tissue beyond the genial tubercle, the patient might have dropping of the chin. Nerve damage if you have a retromolar area grafting. Tooth devitalization if you're taking from the symphysial graft and you cut the graft too close to the roots of the anterior teeth, you might have devitalization. Gingival recession if your graft is not well taken, or your soft tissue is taking in a haphazardly way, and then you will inflict some gingival recession at the site. Infection, hematoma at the site of graft, and then increased post-operative discomfort, particularly if you take the chin graft, if you take it from the chin. This is an important study by Chipasco, year 2006, where they looked at the neural disturbances related to the harvested bone from different sites. And they reported the following. If you take the graft from the chin, the neural disturbances ranged from 10 to 50%. If you take it from the mandibular retromolar area or the ramus, the neural disturbances range from 0 to 5, so it's less. If you take it from the calvaria, the morbidity were extremely low, almost 0. For this reason, chin graft should be considered with more caution, whereas the mandibular, retromoral, or Raymusi graft is gaining more and more popularity due to the advantages over the mental symphysial graft with regard to less neural disturbances. Of course, we don't take from the calvarium, but I mean, this is a study, it involved some graft taken from the calvarium. This is a comparison between graft taking from the symphysis and then the Raymusi. And you see that the one from the symphysis has more advantage, the bottom from the Raymusi rather has more advantage than the one from the symphysis. But in general, if the surgeon has good hands, I mean, they are approximately the same results. The overall survival rates of implants placed in the site reconstructed in the maxilla and the mandible range from 60 to 100%. If the grafts are intraorally, of course, the survival rate are reduced if they are taking extraorally from the hip or from the rib. It will be reduced to 30 to 50%. So the survival rate of the implants, if the grafts are taking intraorally, is higher than that if the grafts are taking extraorally. The implant failure rate in patients grafted intraorally or extraorally ranged from iliac graft, it's 17.5%, from the calvaria, 5.1%. If the grafts are taking intraorally, the implant failure rates are reduced to 2.9%. So the survival rates, if the grafts are taking intraorally, are higher, and the failure rates of the implants, if the grafts are taking intraorally, are lower. So we recommend, if you are going to place implant, to take the graft intraorally to increase the survival rate and reduce the implant failure rates. So this is with regard to autograft. Let's talk about the allograft. Allograft are mainly from cadavers, and it's transplanted from one individual to the other within the same species. There are three main divisions: frozen, freeze-dried, or demineralized freeze-dried. They come in different forms: particulate, gel, putty, or block. So example of commercially available allografts: particulate allograft, they come into three forms. Whether it's cancellous allograft, and I use this mainly in the socket augmentation. Cortical allograft or corticocancellous allograft, but the cortical will be more, 70% cortical, 30% calculus. It comes in the form of demineralized bone matrix putty allograft as well, putty with bone chips, or it comes as block allografts. The major advantage of allograft is that the material is readily available without the need for another surgical site. Yes, it's taken from same species from cadavers, but it's available. You don't have to take it from the patient to avoid any major problems with the donor side that happens during taking the autogenous graft. The allograft mainly osteoconductive, with no or questionable osteoinductive properties. So some companies, they say that allografts are osteoinductive. To be honest with you, they are not. They are osteoconductive, and no evidence-based studies showed that it's osteoinductive. The only osteoinductive is the autogenous bone grafts. They have been widely used in bone augmentation procedures around teeth and implants, and proven to be effective in many of these two forms, whether they come in the form of demineralized freeze-dried bone allograft or mineralized freeze-dried bone allograft. The remodeling process depends on the size of the bone graft, particulates, and the remodeling capacity of the recipient site, i.e. some of them come into bigger size or smaller size, so you have to pick the size accordingly to the procedures you are forming and accordingly to the site you are augmenting. Xenografts, they are materials derived from other species with their organic components totally removed. So the xenografts are inorganic materials. The organic materials are removed from these graft material. The remaining inorganic structure provides a natural architectural matrix as well as an excellent source of calcium. The inorganic material also maintains the physical dimension of the augmentation during the remodeling phases. It is mainly osteoconductive, and it is commonly used and generally well tolerated by the patient. However, compared to allograft materials, they have a slow or a questionable rate of resorption, with data indicating no overt signs of resorption at 12 months and persistence of the material at the implantation site up to 9 years post-operatively. Indeed, they are called non-resorbable material. If you go to the Boozer group, they call the xenograft, like the BioOS, as a non-resorbable material. Last, the alloplastic materials. They are synthetic or inorganic implant materials used as a substitute for bone graft, such as beta-tricalcium phosphate, hydroxyapatite, or bioactive glass material. They are biocompatible but have no osteoinductive or osteoconductive. I call these materials as defect fillers. But sometimes if you have a large defect, you can use them in combination with other allograft or xenograft material to fill the defect. Where do we use these materials? There are different grafting materials in different augmentation treatment modalities. For example, when you do socket augmentation, I usually use the cancellous bone graft if I have the buccal bone intact. But if you have loss of the buccal bone, then you have to use corticocancellous bone graft, whether it is xenograft or allograft. So that's for case of socket augmentation. If you do horizontal ridge augmentation, you have to use corticocancellous bone graft plus autogenous bone chips, or you can use autogenous bone graft to start with. If you use ridge augmentation, in case of ridge augmentation, vertical ridge augmentation, mainly you have to use corticocancellous allograft plus autogenous bone chips, 50-50%, with the Tintic technique, or from the start use autogenous block graft. So it depends on the defect size and the material and the technique you are using for this patient. In case of sinus augmentation, when you lift the sinus, if you have crystal approach or internal sinus lift, use cancellous bone graft or corticocancellous bone graft material. So whether cancellous or corticocancellous, both will work. Lateral window or external sinus lift, use cancellous xenograft, cortical cancellous allograft, or a mixture of xeno allograft material in a layering technique. If you read the Testori techniques, he likes to use layering technique. He starts with allograft and xenograft and finish up with allograft bone graft material. Membrane. Of course, if we're talking about the bone graft material, we have to talk about the membranes, because you have to cover your grafting material with a membrane to prevent it from being lost or from the granulation tissue formation at the site of augmentation. So the materials used for augmentation procedure in conjunction with the bone graft materials are called the membranes. Membranes have the following properties. They have to be biocompatible. They are self-occlusive, i.e. they are preventing the epithelial cells to repopulate the grafted site and preventing it from forming granulation tissue. So we want the site to form bone and not granulation tissue. They are space maintainers. They are clinically manageable, possibly biologically active, and they promote tissue integration. Commercially, they are available into two main groups, resorbable or non-resorbable membranes. The non-resorbable membranes, for example, the expanded polytetrafluoroethylene, they are ideal membranes for guided bone regeneration, particularly if we're talking about vertical ridge augmentation. The non-resorbable are essential for the site augmentation. It is a fluorocarbon polymer that can be reinforced with the titanium or increased strength rigidity, and space maintenance. They consist of two parts, the collar portion and the occlusive portion. The collar portion with open pores to allow ingrowth of the connective tissue and to prevent epithelial migration at the site. The occlusive portion, they prevent the flap tissue from coming in contact with the root surface of the tooth. A second surgery is required for its removal, which increases site morbidity, patient discomfort, cost, and time. The main disadvantage to using the non-resorbable membranes is a high incidence of membrane exposure, leading to bacterial colonization, bone loss, and failure of the regeneration at the site of augmentation. They come in two forms, EPTFE or DPTFE. What's the difference between the two forms of non-resorbable membrane? The EPTFE consists of two layers of porous expanded polytetrafluoroethylene. The first outer layer has an open microstructure portion size from 100 to 300 micron porosity. And the second inner layer has an occlusive portion of less than 8 micron porosity. So this is the form of the non-resorbable membrane or the titanium reinforced membrane to prevent the creeping of the epithelial cells into inside of the grafting material. The other kind is the DPTEF. It consists of 3 layers, an outer part of high density polytetrafluoroethylene with the submicron less than 0.3 size micron porosity and an intermediate grade 1 titanium structure and an inner expanded polytetrafluoroethylene layer. So it comes into 3, outer, inner, and inside layer. A comparison of E polytetrafluoroethylene and D polytetrafluoroethylene titanium reinforced non-resorbable membrane done by Ronda, year 2013, and he found no clinical or surgical differences in a vertical bone gain around implants with during guided bone regeneration using any of these membranes. The observation of an easier removal of membrane and the possible easier management of membrane exposure could support the use of the D polytetrafluoroethylene membranes for vertical ridge augmentation in comparison with the expanded polytetrafluoroethylene. So the D polytetrafluoroethylene showed to be better and easier in removal and less membrane exposure. Next, we will be talking about the absorbable membranes. They are mainly formed from collagen, porcine or bovine type 1 or 3 collagen material. They are synthetic membrane. Some of them are synthetic membrane, consist of polyactic and polyglycolide copolymer materials. Other factors or other materials that are used to cover the grafted site or used as augmentation materials, they are called the growth and differentiation factors. Currently, they are believed to be contribute to periodontal and alveolar ridge augmentation, and the growth factors come into different groups like platelet-derived growth factor, insulin-like growth factors, transforming growth factors, fibroblast growth factor, bone morphoregic protein, BMP. These are considered the most and widely studied materials in the dental literature for bone regeneration. The BMP or bone morphogenetic proteins, they are the induction process triggered by bone morphogenetic proteins, which involves chemotaxis, proliferation, and differentiation of mesenchymal progenitor cells. Recombinant human bone morphogenetic protein type 2 has been found to exhibit very high osteogenic activity in experimental and clinical study. So, bone morphogenetic protein, human recombinant type 2 are very, very osteoinductive and osteogenic that will lead to bone ingrowth at the site of the defect. The effect of such proteins is dependent upon the chiral material, which serves as a delivery system and as a scaffold for cellular ingrowth. So it is very important, but it's very expensive, and the vehicle to carry it is sometimes difficult to be maintained. Okay, the surgical treatment modalities using the bone graft and the membrane material. We called it the guided bone regeneration, horizontal or vertical ridge augmentation. The principle of guided bone regeneration in a horizontal or a vertical manner involves cell occlusion, contact inhibition, tinting, scaffolding, and stabilization. The first technique, the horizontal ridge augmentation, means if you have 10 to 40% of horizontal bone loss, i.e. Simplified class 1, we use a technique for horizontal ridge augmentation. This technique, we can use the autogenous bone block if you have more than 50% bone loss. So autogenous bone block is recommended for horizontal bone augmentation. Or if it is more than 50% available, means less than 50% bone loss, you can use bone grafting material, corticocancellous particulate, or mix with autogenous bone chips. We can use resorbable or non-resorbable membrane, or we can use fixation screws or tacks to stabilize the stabilize the resorbable membranes. Okay, now we're going to go to clinical cases to explain what do we mean. So case 1. This is a patient that has horizontal bone loss, Simplified class 1 in the lower mandibular area. So we use the biogenic membrane, PRF, APRF, and IPRF to stabilize the allograft corticocancellous bone. So as you see, this is the defect side with horizontal ridge augmentation, with horizontal bone loss, Simplified class 1. We did decortication of the buccal bone. We put allograft, corticocancellous allograft, and we soak it with IPRF, okay? And then we use the APRF membranes to cover the graft material, and we suture it with continuous lock. Okay. This is the healing after 4 months, excellent soft tissue and bone graft healing. We put 2 implants at area 4.4 and 4.6, and these are the 2 implants, and this is the ridge for augmentation. Here we have the 3 units ridge for implant supporting prosthesis. Okay, case number 2. We used non-resorbable membrane, titanium reinforced membrane. This is a patient, young guy who lost tooth number 11 in an accident when he was 17 years old, and his age at the time of procedure was 23 years old. Okay, and so we look at the side here. So the patient has horizontal bone loss, Simplified class 1. So we decorticate the plate, the buccal bone, and then we use the titanium reinforced membrane. We stabilize it lingually, and then we put corticocancellous allograft, and then we close the side with the membrane, and these are the fixation screws, and this is after the augmentation procedure. We have 2 verticals, and we close the defect with the no tension at the site. So we want to try to avoid any exposure of the non-resorbable titanium reinforced cytoplasm membrane, and this is the defect after healing. After 3 months, we open the site, and then we see the amount of bone augmentation. We place the implant at the time after membrane removal, and look at the level of the crystal bone at the time of implant placement. This is the bone level Stroman SL active implant. This is the site after healing. This is a temporary crown for 3 months, and this is the final result after crown insertion with excellent soft tissue and integration at the site of augmentation. And this is the periapical radiograph showing the good level of the bone, the integration of the implant, and the crown contact. Case number 3. We used autogenous bone graft, chin graft, to augment the horizontal bone loss. So again, this is Seibert class 1, with horizontal bone loss. So this is the area. Patient is missing teeth number 4 and 4-5. This is the defect side. This is after exposure. We see how big is the defect, decortication of the side, and then we took a block from the chin. We stabilize it, and then we fill the side with corticocancellous allograft, and this is a resorbable membrane. We place it there, and this is apical matrix suture and horizontal continuous lock suture. This is the x-ray after the surgery. We see the block and the screws to stabilize the block, and this is 4 months after healing. Block was removed, implant was placed, and this is the area with the teeth with the implant restored. Case number 4, autogenous bone block was taken from the retromolar area. Again, bilateral horizontal bone loss, Seibert class 1, but this time we used the retromolar area because it's near the site of augmentation. So this is the ridge, and we see the horizontal bone loss. This is after exposure, okay, and then we took a Raymusi graft. We decorticate the buccal bone. We put the graft, and then we put the bone in between the block and the native bone. So this we call this Curie technique, and this is a resorbable membrane, and this is a continuous lock suturing with horizontal apical matrix. This is after 4 months of healing. Look at the nice healing of the implant, and we placed 2 implants here for augmentation. The patient is not restored yet, but the healing was excellent. Second technique for augmentation, we call it ridge splitting or split osteotomy. If you have a bone 3 to 4 millimeter available bone width, it's preferred to use what's called ridge splitting. Okay, it's preferably to be used in the maxilla where the bone is type 3 or 4. The chisel and the osteotome are used to expand the buccal bone facially and create osteotomy site. Corticocancellous allograft or xenograft is used in a sandwiching technique to fill the site where the bone ridge was splitted. Implant can be placed simultaneously if there is stability of the buccal bone, and the membrane placed is optional at the site of the grafting. The technique should not be used in the aesthetic zone because it won't give you a good aesthetic result, particularly if you have a small defect site. Okay, this is an example. We did split osteotomy at the side. Look at the thin, the ridge, how thin it is, 3 to 4 millimeter. So we choose to use the chisel to split the ridge, and after splitting the ridge, we put the implant at the time of surgery, and then here we put a corticocancellous allograft. Resorbable membrane was used, continuous lock suture, and these are the 2 bone level SL-active Straumann implant. We used the Palissy technique to close the flap at the second stage surgery to fill the papilla between the 2 implants, and this is the implants after restoration. Vertical ridge augmentation, of course, you have to use autogenous bone block, and this is the gold standard for graft quality. Horizontal and or vertical bone loss, Seibert class 2 or 3, we can still use the autogenous block graft. As I showed you before, we used the chin graft for horizontal ridge augmentation. Graft immobilization with bone fixation screw is essential. Membrane and bone particulates are optional, and then you have to leave it for 6 to 8 months for healing. This is an example with implant that showed failure. There is soft tissue and bone loss at the side of implant. The decision was to remove the implant, okay, and then augment the site at for soft tissue. We left it to heal, first of all, to grow the tissue. So we put the graft at the site of extraction. And then after that, when we open the flap, we used a chin graft or chin block. And then we placed it here with 1 screw and then we put bone graft, resorbable membrane, we close the side, and this is the side of the donor side of the chin graft. This is the implant placed, okay, and this is the healing with the aesthetic abutment, and this is the final implant restored with the crown, and this is the healing, excellent healing after 3 years. This is the result after 3 years. Patient is very happy and very satisfied. Chin graft, again, we used it for vertical ridge augmentation. Patient is missing 2 teeth, and this is the CBCT showed the vertical ridge augmentation. This is at the site of exposure. We took a block graft, we divided into 2 sections to have more aesthetic result, and then we sutured the flap, and then after healing, 3 months of healing, we opened, and then we removed the screws, and we put the 2 implants, and we closed the defect, and this is after restoration. Excellent result with growth of papilla and excellent stability of the implant. We can use a Raymusi graft for vertical ridge augmentation. This is a patient with implant failure that was referred to me to remove the implant. After implant removal, look at the huge defect, soft tissue and bone loss in a vertical manner. The mental was really exposed to the crest of the bone. We did first soft tissue augmentation, FGG, and after 8 weeks of healing, we opened the flap, we locate the mental, we took a Raymusi graft, and then we fix it at the side, and we close it with continuous lock suture and horizontal apical matrix. This is after healing, excellent soft tissue and vertical bone gain. We put the implants, splint them, and this is the prosthetic part after 3 years of healing. Tenting technique, we use it for vertical ridge augmentation. If you have Cybert class 2, when you have vertical bone loss, we put the tenting screws, and then we put mixed Otogenous bone graft with bone particulates, Allograft or Xenograft, and then they will be stabilized by the tenting screws. We have to use resorbable membrane or non-resorbable membrane. It depends on the dentist option. The membranes has to be fixed, stabilized, and then has to be covered with good soft tissue coverage. Okay, this is a case where the patient in an accident lost the all teeth together with the bone. He came with no tissue and no bone in a vertical bone loss, and this is how it looks at the beginning. So first of all, we did FGG to augment the soft tissue. After healing, 8 weeks of healing, we opened the side, and then we used the fixation screw that was used to stabilize his mandible. I put it here, and then we put corticocancellous allograft under the tenting screws and the tenting chain, and then we cover it double layered resorbable collagen membrane, and then we close it with continuous and apical matrix suture. This is after 4 months of healing. You see the bone that has been formed. So the screws and the blade was removed, implant was placed, and this is after 3 years of healing. Excellent healing for this patient. His life is totally changed. Okay, in conclusion, bone grafting has become an essential part in the augmentation procedure required for periodontal and implant therapy. Different grafting materials are available with variable compositions and characteristics that should be known before they're used. Site specification and treatment procedures are important factors in the selection of appropriate bone grafting materials. Autogenous bone graft is the gold standard technique at site with advanced bone loss. Case selection and operator's knowledge and skills and experience are very important key factors in long-term survival and success rate. So, for optimal result, we have to merge knowledge, technique, and skills to get the optimal result you are looking for. With that, I thank you very much, and this is my the sites that I'm available at. If you want to contact me in my WhatsApp, Twitter, Instagram, Facebook, or Snapchat. I always put the favorite thing and the thing that really I'm honored to achieve. It's the King Abdulaziz First Medal Prize that I got from the Saudi government, and I'm very proud to have it and very honored to have such an achievement and such an appreciation from my government. With that, I thank you very much and wish you all the best. If you need anything, any help, you can contact me on one of these social media sites. And thank you very much for listening to me.